everybody, and good morning. Welcome to the topic today, which was listed as ENT POCUS, but it's actually point of care ultrasound of the face without the ears or nose. So today what we'll be talking about is a few things. So we're going to talk about understanding different approaches to the face and throat ultrasound scanning. We're going to look at some of the evidence to support different approaches and discuss ultrasound assistance in peritonsillar abscess drainage. So the first topic we'll talk about is the facial sinuses. So our first case is a 15-year-old girl who was previously well until she developed a long-standing fever for 25 days. She had had some symptoms of cough and coryza and then developed nasal purulent discharge, but had no headache or facial pain associated with this. And a normal examination when we looked at her on physical and with her vital signs. She was afebrile at the time we saw her with an elevated ESR and CRP, but a normal white count, a negative throat swab, monospot, mycoplasma, PCR, nasal pharyngeal swab, and chest x-ray had all been done in the past. So when we think about sinus fluid, we know that ultrasound is well established in assessing for sinus fluid in intubated patients. In emergency point of care ultrasound, there's pretty good sensitivities and specificities compared to CT for assessment of these areas of the face. There's a high specificity for clinical importance because clinically important sinusitis requires significant fluid. So when we think about how we're going to measure this, a lot of people will be familiar with plain films of the sinuses that hope to catch an air fluid level present. This, of course, can cause exposure to radiation of the patient, but in addition can be a little bit more uncomfortable. When we think about approaching this from an ultrasound perspective, we have to get oriented to our anatomy first. So when we think about our transducer, we're going to be using a linear transducer and we're going to be placing it longitudinally on the face with the marker pointed towards the eye and the bottom end of the transducer pointed down towards the chin or towards the lip. Here in this picture, you can see some soft tissue, a little bit of bony prominence there with a cortex, and then we see this sort of dark grouping underneath that, and that's your actual sinus. To give you a better understanding of how we want to think about sinuses in terms of ultrasounding them, we like to use a glass of water. So whether this glass is half full or half empty, we're going to try and look at the air and the water with our transducer. In putting our transducer as we would on the face, we can assume that what we might see is nothing much through the air, as we know air is not the friend of the ultrasound machine, but we may be able to see quite a bit deeper in the area that contains fluid. So here, on the other side of that same face that we looked at before, you might be able to appreciate that all of a sudden you can see the posterior wall of that sinus. That implies that there's an air fluid level present, and we're actually looking through fluid at a certain area to be able to see that posterior wall, whereas in another side, we can't see it. So just comparing side to side, here are two sinuses, one full of air and one with an air fluid level, and you can appreciate that posterior wall. That's really what we're looking at when we think about a sinus ultrasound. For those of you who have problems tilting your head, I've now made my strange face go the right way up so we can hopefully appreciate it a little bit better. So at the top of your screen should be your eye. Remember, your transducer is going longitudinally along the face. Then we have this pocket of air with all of a sudden on the left-hand side of your screen, a visible posterior wall compared to the right-hand side, and then the bottom of that transducer near the lips or chin. To make it a little more apparent, I've drawn in the fluid for you. We're not going to be able to visualize all the fluid itself, but it gives you a sense of what we're looking at. So remember for your ultrasound of sinuses that it is specific for maxillary sinus fluid, but that this fluid does not always equal sinusitis. They have to have the history of the ongoing fever, possibly some abnormal laboratory results, and potentially some findings on physical exam to help corroborate this. Remember to look for the posterior sinus wall so that you have to keep in mind what air can do with ultrasound and what fluid can do with ultrasound and the value of seeing deeper with that fluid. Some of the complications that you can get with ultrasound, with sinusitis, include other findings in your sinus scan. So here, for example, is a transverse and sagittal view of an ongoing facial pain and swelling. Unlike the previous picture, you might notice some thickening and some early cobblestoning of the soft tissue anterior to that bony cortex. That's that bright white line that you see on your image there. This is actually a sagittal maxillary sinus fistula that was found in a patient with prolonged sinusitis. Another complication that we've seen is this. So with prolonged sinusitis that goes untreated, sometimes we're at risk of developing increasing areas of abscess formation and soft tissue swelling located in the forehead. This was described in a paper, but we've also seen it clinically here. If they've got worsening headache with facial swelling, we want to think about a Pott's puffy tumor, meaning thickened tissue and abscess near to and possibly involving an intracranial aspect. Here's a CT to show you that same type of patient where you can see both an intracranial and a soft tissue abscess formation secondarily. Our second topic is going to be peritonsillar abscesses. There's two approaches that we can ultrasound for peritonsillar abscesses, and we'll talk a little bit about both of them. So the first approach is your transcavitary approach. This is using your transcavitary probe or some other probes, which we'll talk about a little bit later. And the goal is to directly visualize your tonsil with contact to that area. It's important if you're undergoing this type of ultrasound that you have proper infection control in your site. Often these probes have to be cleaned specifically by the hospital and cannot merely be wiped down. They also require a sterile casing. The other way that you can look for peritonsillar abscess is the transcutaneous or transcervical technique that we'll talk about as well. This technique is great because if you have trismus, it allows you to see without needing to open the mouth. It also means that you're not needing to undergo that infection control protocol, and it's often well tolerated by patients. So there's a few studies that look at this, but this is a nice summary paper that I encourage you to read if you want to get more information. So intraoral ultrasound has been compared to landmark for needle aspiration, showing improved accuracy using an ultrasound guided technique. And we'll talk about what that technique might be a little bit later on. Studies have also shown that there's a 7-fold decrease in subspecialty consultation over just simple landmark and physical exam, and a decrease in CT rate from landmark and physical examination as well. Comparing to that, we'll talk about the transcutaneous approach. So the transcutaneous approach, depending on the study you look at, and these are summarized in the above paper, show a sensitivity of 80 to 91% and a specificity of 80 to 93%. If trismus was present, the transcutaneous ultrasound can diagnose abscess in 100% of the patients surveyed in one particular study. This study that was recently published in the laryngoscope goes a little bit further into assessing transcervical ultrasound. These were done in a less than 10-minute protocol by radiology technicians trained in cervical ultrasonography. It was a retrospective analysis between control and ultrasound groups, and they found that the ultrasound group was less likely to order CTs, but there was no difference in the proportion of negative CTs. They were also less likely to have a procedure and less likely to have a long stay. Readmission within 30 days was not significantly different, nor was ENT consultation in the emergency department. They did a cost analysis in their American Center and found that there was a cost reduction from $510 in the non-ultrasound group to $298 in the ultrasound group. Importantly, the way that they stratified things was they suggested medical treatment if they had evidence of tonsillitis, phlegmon, or small abscess, and defined surgical drainage either at the bedside or in the operating room if the abscess was at least 1.5 centimeters in diameter. Treatment failure in the ultrasound group was 8% compared to 14% in the control group, but this was not significant in their study. So now to look a little bit at how we're going to do these tests.